44 pending prior authorizations in the queue. The endocrinologist is already 45 minutes behind, and the front desk coordinator just called in sick. This is a real Monday morning for a mid-size endocrinology practice in 2026. Buried in that queue are 6 GLP-1 starts waiting on payer approval and a peer-to-peer review scheduled for 11 a.m. that no one has prepped the historical HbA1c documentation for. What began as a narrow cost control checkpoint has expanded into a massive, resource-intensive workflow that actively pulls time and capital away from patient care. High volume is only the surface of the problem. When we look at how these requests are adjudicated, a structural anomaly emerges in the data. For the average endocrinology practice, 31% of prior authorization requests are denied on the first pass, but when appealed, 81.7% are overturned. This proves these initial denials are rarely based on valid clinical rejections. Instead, cases are failing over minor clerical deficiencies, a missing BMI entry, an incomplete step therapy log, or a payer policy language mismatch. Practices relying on generic prior authorization forms consistently see higher failure rates compared to those using meticulously structured, guideline-matched EMR documentation. The gap between a first-pass denial and a successful appeal represents thousands of dollars in recoverable revenue lost to inefficient internal workflows. Endocrinology prior authorization is particularly difficult because a practice runs multiple, highly complex documentation tracks simultaneously within the same office. Take the explosion in GLP-1 receptor agonists. According to Penn LDI research, prior authorization was required for 5% or fewer of Medicare beneficiaries on these drugs before 2024. By 2025, that requirement jumped to nearly 100%. Submitting a GLP-1 indicated for type 2 diabetes requires an exact sequence of proof, an HbA1c threshold above 7%, and a documented trial of metformin or a sulfonylurea. Yet prescribing a variation of the exact same molecule for weight management triggers a completely different pathway, demanding BMI minimums and detailed evidence of lifestyle modification attempts. In parallel, the practice is also securing authorizations for hardware, like proving insulin-requiring status to get a continuous glucose monitor approved. Because payers rewrite criteria annually, human-only staffing models cannot process this volume without driving up error rates and staff turnover. While internal practice chaos mounts, the federal government has introduced strict new regulatory pressures on the payers themselves. In January 2026, the CMS 0057F mandate went into effect, creating critical new leverage for healthcare providers. This timeline visualization outlines the new compliance windows. Impacted payers are now legally required to issue decisions within exactly 7 calendar days for standard requests and 72 hours for expedited cases. Even with tighter timelines, the peer-to-peer review process remains a major bottleneck. Current AMA data shows only 15% of physicians believe the reviewer on the other end is actually qualified in their specialty, who may have never managed the condition. Practices are caught in a dual trap. They must execute flawless, complex documentation faster than ever before to hold payers to the new CMS windows, or risk losing valid cases to an attrition-based payer system. Solving this requires moving away from general medical billing services and toward an architecture that integrates artificial intelligence with endocrinology-trained human specialists. The operational objective of this new model is precise: achieve a standard 4-hour turnaround time for submissions while driving case abandonment to 0. This sequence shows how the system functions. First, a clinical reasoning engine powered by AWS Bedrock accesses the EMR and begins scanning the patient's chart. During the extraction phase, the AI quickly isolates critical historical variables, pulling exact HbA1c trends, prior medication trials, and BMI calculations from physician notes. It then cross-references those variables against current ADA standards of care and the patient's specific payer policy, automatically drafting a structured medical necessity narrative. By organizing the data this way, the AI layer handles roughly 80% of the repetitive keystrokes and clinical synthesis. Automating this extraction directly eliminates the minor clerical errors and missing data points that are responsible for the massive 81.7% overturn rate we discussed earlier.
Once the documentation is pristine, the system transitions to routing and compliance orchestration to ensure the case accurately reaches the payer. This flowchart illustrates the N8N orchestration layer, which takes the drafted submissions and routes them directly through required digital portals like CoverMyMeds or Availity. The system then enters a proactive 4-hour polling cycle, constantly checking for status updates to prevent cases from expiring and holding the payers to the CMS 0057F timelines. Overseeing this automation system is a critical human safety net, an AAPC credentialed specialist trained specifically in endocrinology workflows. This specialist owns the 20% of the workflow that technology cannot resolve. They provide the nuanced clinical judgment required for complex payer relationships and edge case resolutions. They also execute a strict peer-to-peer prep protocol, briefing the endocrinologist 30 minutes before a call with a pre-organized timeline of prior therapies and exact endocrine society citations. The AI provides the speed and scale necessary to process the sheer volume of GLP-1 starts, but the credentialed human provides the clinical precision required to convert complex reviews into final approvals. For practices looking to adopt this architecture, the decision ultimately comes down to operational economics. This split-screen comparison shows the financial baseline. Maintaining a fully loaded, in-house prior authorization coordinator can cost up to $84,000 annually and carries severe risks of turnover and lost institutional knowledge. In contrast, deploying an outsourced Staffingly AI team operates at roughly $20,000 annually per role, entirely neutralizing staffing friction and constant retraining. The service is fully HIPAA and SOC 2 compliant, and because it operates directly inside the practice's existing EMR, deployment takes just 5 to 10 days. It is an architecture already trusted by over 800 healthcare providers across the United States to manage their highest burden workflows.